Good morning. Thank you for joining us for this presentation in the Toxicology and Societies, the Impacts of Chemicals in Our Live speaker series. I am Ruth Sofield. I'm an environmental toxicologist and chemistry professor at Western Washington University. My co-host, Tracy Collier. Hi, Tracy.
Hey, Ruth. Good to see you.
Is a toxicologist who is retired from NOAA's Northwest Fisheries Science Center and continues his work as a consultant. We would like to begin by acknowledging that we at Western Washington University are on the ancestral homelands of the Coast Salish peoples, who have lived in the Salish Sea Basin throughout the San Juan Islands and the North Cascade watershed from time immemorial. Please join us in expressing our deepest respect and gratitude for our Indigenous neighbors, the Lummi Nation and Nooksack Tribe, for their enduring care and protection of our shared lands and waterways. And now I'd like to go over a few logistics. We will save questions for the end of the presentation, but you can use the Q&A feature on your screen at any time. You will be muted throughout the presentation, so we will use this feature to interact. The focus of our speaker series is to provide understandable examples of how events with a toxicological component have consequences to people and societies. We are happy to welcome Dr. Lorelei Walker today. Lorelei is an experienced public health professional, community advocate, policymaker, leader, labor leader, and science educator. She has a PhD in public health from the University of Washington School of Public Health and is currently the director of public health training for the Social Safety Initiative. Today, Lorelei will talk about a nationwide effort to determine effective cleaning and disinfecting practices in licensed childcare facilities during the COVID-19 pandemic. Welcome, Lorelei.
Ruth. Shall we get started? All right. So yes, my name is Dr. Lorelei Walker, and I'm going to roll right into a slide deck. That'll keep me on time. And here we go. And I'll just let anybody stop me if it turns out you can't see it. Okay. So let's talk about gaps in health equity during COVID-19. So specifically, we're looking at disinfectant use in childcare sites, impact on priority populations, and then opportunities for the future. So I have a master's and a PhD in public health genetics from the University of Washington. Right now, I am the director of public health training and the founder of the Social Safety Initiative. We are a volunteer nonprofit. I speak my story today. I do not represent any of the institutions that I have worked for during this experience. My story is my own. However, the Social Safety Initiative does stand with this story. And so I do not have any conflicts of interest. There we go. I want to express a deep appreciation for this invitation to stand in discourse with champions who have had this platform in the past and to come, and a deep gratitude to speak to this audience. Far and wide, this audience is protecting our generations and those to come. And I want to acknowledge all of the environmental health champions, the past, the current, and the future, spread across this state, our counties, the nation, and the globe. You are the guardians of our flock for this generation, and that is not lost on me. So, there we go. So problem, barrier, solution. Increasing risk for poor lung health outcomes. This is a problem during COVID-19. There we go. Disinfectant misuse and overuse in early child education centers, ECE sites. I'm going to call them sites. These are childcare sites. 0 to 4, they're licensed by the state through a licensing agency. Now, ECE sites need education and training. Where is the threat? SARS-CoV-2. Where is it? Surfaces, air. These are essential sites, not frontline workers, essential sites. We really need childcare during that time. What do disinfectants do? And how do we safely use disinfectants? So what's the solution? Well, CDC and ATSDR have a real-time response. Now, you get these slides later. So if there's stuff you want to dig into, they'll be here. You can watch this later. Just let it wash over you. So the Apple Tree Grant is a grant across the nation for states focused on safe siting of childcare sites, not indoor air quality, but the soil and the air and the land around. The supplemental grant was an immediate response, a national collaboration. It was issued to 17 states, and it had a prominent nonprofit who did the organization across all those states, which is important because we all need to cross collaborate and talk about things that are going in real time. So the DOH, they get this single FTE for a technical expert for 7 months, but it's embedded in the DOH. So there's resources, there's a communications department, they handle translation, health educator on the project. There's video, media, website. And so this work is embedded in an institution where it can be successfully distributed to local health jurisdictions and to communities. So let's go ahead and educate and train licensed childcare education centers on disinfectant safety. That's our goal. So who they hire? They happen to hire me. So I'm an applied systems thinker. Now I'm going to take a moment to describe what that is, because we have students on here, we have early professionals, and I want to give you some imagination around what that can look like. My cohort was one of the first interdisciplinary trained cohorts, but the students and the early professionals coming in now are already interdisciplinary trained. So here's some imagination. Didactically, environmental embodiment, how the environment moves epigenetic mechanisms, move towards disease outcomes, especially with toxicology. You can read my dissertation, it's for public health professionals. Systems determinants of health. Now we talk about social, but systems determinants and how to be a translationalist between those systems, life course strategy and the stress response system, evolutionary biology, and the stress response system becomes a critical piece for public health professionals to know, because if you know what triggers a stress response system, you can bypass it and you can move into a state of learning. We can have a common conversation. And then in practice, I got trained as a community organizer and became a health equity leader in the community. Started a course at UW with colleagues called Health Equity and Community Organizing, mostly for med students in the med school, to learn how to organize with their clinics to make change in their community. Started Seattle and Spokane. Now it's 7 states. It's its own nonprofit, Health Equity Circle. You can look it up. Policymaker and labor leader. What does that mean? COVID-19 hits. I'm the standing co-chair of a coalition of 7,000 King County workers. Now, these are not the nurses. These are not the doctors. These are your social workers. These are your frontline workers. These are your admin in the clinic, but it goes beyond that. So safety becomes a priority. We actually got 6,000 frontline workers masked through the unions 5 weeks before the CDC changed its regulations. That's critical. That's a point of movement where we saved lives, especially being at the first site where this came down. But there's also more opportunity. If you know public health and you know systems, we got labor policy opened. And I'll take just a moment to tell you what that means. The council, the exec office, and the union sat down and opened up the policy that gives the exec office the guidelines for negotiating with labor. There's a compensation analysis that happens every year to 2 years. The county goes and looks around the local area and says, okay, social workers, you seem to be paid with benefits 20% above the average. So we're not going to bargain any wage increase. In fact, they hadn't had one for 10 years. They had COLA, but not a wage increase. And so there are occupations that are historically held by women and women of color because other occupations haven't been available to them. And so we got one little bulletin I championed that said, the county must account in wage compensation for historically oppressed occupations. Might be the first one in the country. It's sitting there in policy. It's sitting there to be used. But that is one way you can bring a health equity lens into something that's a well-worn system of labor negotiations. So just as an example, that's a place for movement. A community advocate, trainer, public health trainer, and I'm going to point out I identify as neurodiverse. So I have NAMI Seattle up there. If you are neurodiverse, you identify as that. Solidarity, it's a struggle right now in life and through life. And if you love or care for someone who identifies as neurodiverse, thank you. It's a critical support system. Okay, so back to why we're here. So we want to decrease disinfectant, induce poor lung health outcomes. We want to create positive health behavior change, specifically at ECE sites. So who are these ECE sites? What's the catchment population? Now, mind you, Department of Health hasn't been funded to have one person dedicated to all of the ECE sites for indoor air quality. In the schools, all of the schools, they have one champion who is devoted to the indoor air quality program. One person, no one for childcare centers. So I'm filling a gap that hasn't been filled for a long time. So we got to know who we're working with, and then we need to use a health equity lens because there's limited resources, limited time, and we got to know how that's going to shape the plan. All right, there's a lot here, but hang in there with me. The catchment population, 4,800 licensed childcare centers across the state. Now, here's the trick. 1,700 of them, about 40%, are in structured centers, over 12. The rest are home-based, under 12 in capacity. So these are your friends and family networks. This is the person down the street that can take in a couple of kids. They can do that while you're working. Mind you, I really relied on childcare when my daughter was 0 to 4. And it was $1,400 a month. It was the same as basically our mortgage. The home-based centers have more flexibility in that. They don't have as much overhead. This is a very important group. Now they serve 31,000 children. So we're talking about 20% of the kids versus the centers. And then there's the language differences. So there's 7 spoken languages in the state that are not English as the primary in these sites. They span both home and centers. King County has a very expansive language diverse need. But what does that mean if we want to have successful outcomes on this project? Well, we have an existing pipeline. It's stable, it's structured. A lot of the sites are in places that have janitorial staff. Now, why is janitorial staff important? They're trained in chemical use, disinfectants. Disinfectants are indoor pesticides. They're classified as indoor pesticides. And so 40% of worker-acquired asthma is in the janitorial classification. If you can smell it, you're breathing it in. So even trained staff are at a high risk of acquiring asthma from work. So you have trained janitorial staff access, and you also have easy staff training access because there's ongoing systems for all of the staff to get together and to learn something. Home care systems, you got like one person, 1 or 2 people. Also, they have access to a janitorial supply contract. So the state has contracts that if you meet certain qualifications, nonprofits, government, schools, tribal organizations, you can buy into a bulk purchasing mechanism. Now, this contract is a green contract, which means environmental health champions in the past has made sure that what you purchase at 2/3 the price is going to be safer and healthier, fragrance-free. It's not going to be the old clots. You can learn about this in some of the materials. We'll follow up with you. But the essential workers, the child cares that are for-profit, do not have access to this. So these existing institutions, they can get drop shipped, $50. They can have a rolling cycle. The stuff's there. They get the training to use it. And the licensing approval is a lot easier. So what's that? The WAC says bleach or alternative for disinfecting. Or alternative. Alternative requires a form. What language is in it? You know, how are the licensors trained? These are variables. So that form is approved by the health specialist over at licensing. And then the inspector, they would ideally have a list of products and chemicals The inspector would see it matches the list that the person has, and then they can use this process as long as the person can get access to it. Now, bleach is there. You can pull bleach off the shelf at the grocery store. But that one piece of paper is a big barrier because the Department of Health doesn't put out a list of chemicals or products that the health specialist can use in licensing. So that's a gap. So now we have this other pipeline that's fragile or new. Single operators, you need more trainings to go on. Trainings are harder. There's a great nonprofit contracted with the state who can do Somali, Spanish, English trainings, take people the whole way through what's needed. But it is not an easy system to become a trainer. I wasn't able to make it through the process in 4 or 5 months in order to get training out as a part of that. Of course, for-profits are excluded from getting this chemical purchase and licensing involvement I just mentioned. And then of course, there's the language barriers. And not just language, when you're doing translation, you really want to be able to translate the message in words that the receiving population uses. So low success outcomes, this is widening the health equity gap. So where do you start? You do listening sessions, 30 of them. I managed to pull off December to January. And you do a thematic discourse analysis. If you've never done one or you're interested in one as a student, it's great. You don't have to be highly skilled in it to learn and be successful, and you just get better through life. Reached out to these organizations, found the person is usually the one person or a person, 2 people. And then went through and did this. And then what did this do? The gap analysis informed what the project would look like. What do we need to know? And then what can we do? So disinfectants, we need to know what is a safe surface. Where is SARS-CoV-2? Where does it hang out? How does it hang out? What disinfectants are hazardous and what are their health impacts and how do we use them? Grant deliverables, what can we do? Well, we get national expert agreement. Takes a lot of us all talking across the nation and the world. And we make, this should be educational guidebook, and then partner with another nonprofit to do infographic. Those are deliverables we can do. Now the barriers, and this is where DOH wants to be accountable to move the equity needle, to close the gap, not widen it, is get the safety training out there. Fix the language access for local health jurisdictions to use who don't already have that in-house. And then get this limited integration going so everyone can talk and advance what we need. So the equity opportunities, okay, we got to get the products in their hands, the right products. We got to make it easy. And we got to make it easy to fill the form out. And for the licensor to know, that's the form that says yes to that chemical, we're good there. And then they can put it in with the licensor. So there needs to be institutional integration, because that's a lot of institutions that need to work together just for this one outcome. And DOH, there's bleach or alternative. DOH, if we could pull it off, if they could pull it off, not with them now because the grant ended, have a list of chemicals that are approved alternatives and even product names. It gets dicey when you put product names out. That would streamline the process. Okay, so we need a knowledge upgrade in order to do this work. And I promise I'm getting there. I'm getting to the reason you're here. So we need a knowledge grade across the world. Okay, so into 2000, 2001, into 2020, 21 and 22. First, it's an aerosolized virus. We got to get everyone on the same page. It's not on surfaces, it's in the air. There's a viral load you need to hit. You have to inhale so much of it, whether it's a glob of somebody else's cough coming in, high viral load, not just in the air, it's being projected. Or if you're standing around someone for 15 minutes talking in 24 hours, that exposure time is enough to infect you, asymptomatic or not. So then as we move into 2021, okay, now we're realizing collectively as a community, public health was on top it faster, the research scientists were, but getting that information out and getting everyone on the same page and creating whole new systems in order to do this education and training, that takes time. Man, people move fast in public health. They really pulled it off. Breathing shared air. So now we're in Delta here. So we're close contact. Now we're breathing shared air. Now we move into 2022, we've got Omicron. Now Omicron, that stuff just likes to float around on the dust, hangs out. And so now our concern we're becoming aware of is sharing breathing air. Now this graphic represents kids in a school bus. I just wanted to zoom in and you can see how breathing air becomes shared for everybody in the room. You can learn more about ventilation. You can learn more about COVID safety on our website. Ventilation, soap and water, masks, social distancing. So for us, SARS-CoV-2 prevention, guess what? Regular cleaning works. Fragrance-free, soap and water. 20 seconds, scrub the grime down, okay? You got to scrub the stuff off. But it's a weak shell. You can pop it with soap. I mean, there's other things that can hang out in your surfaces you want to be aware of. But regular cleaning works as prevention, okay? Hot zones, you get to a place where people are touching, they may be wiping their face and touching. There's just a higher viral load risk. You're not going to get it from the surface. If somebody sneezes on the surface and then you wipe your face, that's a high viral load. So prevention, sanitize. You got to scrub the grub off. If you don't scrub the grub off, you're sanitizing the surface, but just the surface. You have to scrub the surface away so that you can get down. There's usually a contact time. Pay attention to the contact time. Otherwise, it's all for naught. And then disinfection. So disinfection is treatment, indoor pesticides. So you disinfect in 4 situations. 1, blood. 2, vomit. 3, the word we use with childcare centers, it's important, poop. And then 4, when someone's been sick. So basically body fluids when someone's been sick. When someone's been sick, air the whole room out, bring in the disinfectants, and just get everything out. Now, why does bleach for a lot of us smell clean? Chlorine smells clean, mainly because when someone was sick in the past, bleached everything, person felt better, we felt like the surfaces were safe. That is a behavior that we really need to pay attention to because this is treatment. This is not prevention. We want to be in prevention. Okay, so now, disinfectant knowledge upgrade, public health education. So this is where the grant sits. Now, this is not for reuse, what I'm showing you, because the Department of Health is focused on EE centers and the whole package, the whole deal is making it through the pipeline. What I am showing you on the left is that information, the Social Safety Initiative with approval, was able to take portions of that and turn it into a guidebook for just anybody. It's not focused on childcare. That will circulate a link either in the chat or as a follow-up so that you can just register and we'll send you the guidebook. You can also download it right now on our site, but it'd be easier for us to just send it to you. So that's the cleaning, sanitizing, disinfectant, what it does, when to do it, where to do it, how to do it. So this covers the very specifics, what you need to know, what you need to do, how you need to do it. And then there's probably about a page or 2 on each section. So you know when you're cleaning, you know, the fragrances, no. Antimicrobials, no. Bad news bears, extra chemicals, not needed. When you go to sanitize, bleach has sanitizing concentrations, contact time, alcohol, 70% alcohol is sanitized, steam, hot water, all of these things that you already use. You can be confident to know it works for SARS-CoV-2 to protect you from COVID-19. And then when you do need to disinfect again, you got to clean. When you do need to disinfect, how you do it, ventilation, safety gear, concentration, contact time, these things to be aware of so that when you use the behavior, you've got this knowledge in hand. Now, the chart was in DOH in partnership. This is not something that's up for circulation right now, but it's basically done. It's just getting through the pipeline. So you can see here this beautiful chart. It's able to be translated. You can just see, oh, concentration differences. Get the gear on, the safety gear. If you can smell it, it's in your lungs. Ventilation, that kind of stuff. So these are quick checks that will be instituted in behavior change, especially in places that don't have janitorial services. There we go. But training, okay, so why is training important? You go to drive, you go learn to drive, you get your driver's manual. You're reading your driver's manual. You know that when you're going fast and you need to stop, you brake. You know that when the conditions, it's raining, things like that, drive slower, brake, so you have further distance. Now, you get in the car, you start to learn to drive. Now you're in training mode. Okay, brake, except on black ice. You got to spot it. Usually if there's a bridge, air running underneath, you get the black ice, different situations. So why is black ice important to know when you get trained? Because if you go over black ice, you do not hit the brakes. That has poor outcomes. And so we learn the nuances through training. We also learn the root behavioral programming. Go through first grade, get fire safety training. Unfortunately for my daughter, she's in second grade, she now gets active shooter training. We call it in case the bears are around. So this is just training. So you got your guidebook, but now there's also, now this is a part of the social safety initiative for free online, a janitorial plan, how to make a safe and effective janitorial plan. This is by a gentleman you can read on the website or Teachable website. He's responsible for janitorial services for a major, checking my time, for a major school district, 17,000 kids. And what he's done is he's made small snippets, 8 of them, that can take you through, and an Excel spreadsheet. You just type in your rooms, you type in the surfaces, you type in like trash cans and these kind of things, and it will tell you how many full-time equivalent staff to clean effectively, disinfect when needed, these kind of things. And then there's also metrics to evaluate. So you don't have to guess. There's no conflict. Do you have enough people? That can create problems. So there's trainings on there. And then 2 training videos. We have them on our website. They're pushing their way through the Department of Health package, but basically 3 minutes on cleaning, sanitizing, and disinfecting. You just watch them real quick, get the info. The Social Safety Initiative, we've embedded as one of our protocols, safe cleaning and disinfecting, but we have more things on social hygiene, English, Spanish. People came together. The Covella versus the World is a 3-minute film where Cirque du Soleil performers and other performers in Vegas that were out of work, everything was closed. They came together, we pooled our resources, and we created, I think, the best public service announcement, performing arts, public health, to teach the protocols. And the hero is the worker responsible for the indoor restaurant bar, and he's got soap and water. And he takes on Covella and her transmission minion. It's a really interesting way to train on public health. So the nonprofits spreading the network of knowledge are all volunteers. So let's loop this back to the equity. So I kind of went out a little bit further on that training part. So right now we've got a generation, of children, and there's not capacity to have dedicated eyes on the health of these children. It's there in different institutions, different environmental health champions. It's getting chaotic though. COVID is really stretching everything thin. It's moving people around. COVID is also putting a very big burden on our environmental health. Think about the extra waste. More trucks going to the dump. Roads are deteriorating. Wear a mask, you're open mouth breathing. What does that mean? Rates of cavities go up. There's going to be waves that we're going to see. So for this population, we've got the childcare sites, the licensed one, both types. We've got interfamily. I mean, not even in the licensed setting, just needing common knowledge to come out. You can't use the disinfecting wipes just as a wipe. Children under 18 should not be using bleach, against the law. And so now it's time for institutional change. There's no villain in this. There's nobody doing it wrong. We're just expanding our systems, and it's time for integration. Now, as individuals, we can all normalize our public health knowledge. You go to the doctor, you find out I have cancer, you go to an oncologist for treatment, for chemo. Not mom's St. John's wort or grandma, okay? You have a pandemic, you go to your public health professionals. We're doctors of the community. That really needs to be something that people know and trust, doctors of the community. We need advocacy for environmental health, even if it's just in discourse. Let's be aware of what's going on. And then we need these social public health behaviors, these protocols we all participate in, just like driving on the road, we've all agreed to participate in certain protocols. Now, communities, accessible education, this has to be a priority, and it takes dedicated resources that are beyond the capacity of most of the institutions now. The common protocol training, everyone goes through first grade. Everyone can go through this training, it's not hard. And then interpersonal support, so that we're really supporting each other in doing these behaviors and not questioning, or what research did you know, or it's just like, no, public health says this. Research evolves, science changes, public health does the interpretation, but we need to support each other. And then the institutional change part comes, we need to institutionalize the knowledge. These champions that have programs that are now being knitted together, they're volunteer work groups. There's parts where people can get a sliver into the grant they're working for, but they need to talk together to share what people are doing. They need to have succession planning so that when they leave, the knowledge doesn't leave with them. And then this civic engagement, you've got government, you've got businesses. Oh my gosh, businesses are just, you're doing disinfectant hygiene theater at this point. Nobody really has a grasp on what they're doing and if they're being safe, and they're scared, but they got to stay open, the workers. And then we need really some expanded imagination for funding. The check boxes, they don't integrate the work. And when you integrate the work, your deliverables aren't necessarily captured on the front end. Now, the apple tree supplement was fantastic. Lower disinfectant use. Here's an organization that's going to handle the coordination. That was a great example. But public health and everything, health equity and all policies, this takes dedicated FTEs, it takes dedicated staff resources, it takes phones that work in counties and public health that are scaled down to 3 or 4 people and their phone system isn't working. This really needs an overhaul, and it's called Public Health Matters. It's been going on for years in the legislature. Individually can find out about it, talk about it in the discourse, move institutional change. So fund the work groups, institutionalize these pipelines, because then we can advance community-centric, health-positive behaviors. Now, the fun part, what we can do right now that's exciting is develop ongoing cohorts of public health trainers to train communities. Now, what's a public health cohort? Well, it's our next generation of leaders. Everyone that goes through a Master's of Public Health program has to do a practicum. They really want to do a practicum in a safe sandbox place with mentorship where they can make actionable change. They can be a part of writing a guidebook. They can be part of an educational campaign. They can, our 40-minute free training, Captain Dave Clement with the Air Force, he went ahead and co-wrote that and delivered it. Master Sergeant Erica Massey, right now, she's formalizing that cleaning guidebook to make it more accessible. All of these people, this is just in the last 4 months, they're fantastic. And that brings back to us this infusion of new ideas, the newest science. One individual is not responsible. Many brains make one mind. It expands the environmental health footprint, because wherever these students go in life, they will have this understanding of environmental embodiment, environmental health through a health equity lens. And between all these students, oh gosh, we hit like, I don't know, 1,000, 1,500 hours. And it's a nonprofit site. You have to be cited somewhere outside your institution, so it works well. I'm a site supervisor, but sadly, they pay for the experience. But as far as public health institutions are concerned, it is not an expensive endeavor. Not at all. You really only need 1 FTE. And then if you're kind, stipends for students. or if you had the access to it. These are just some of the universities listed here. So what? We need a professional training program, because then those things, that capacity, the language, training out from the community, having the community train, that's what we need. When? We need it now. Now is when the environmental health wave of COVID is happening. Now is when people are getting into public health. Now we've got excitement for it. Where? It's got to be centralized. Doesn't have to be centralized in an agency, but it needs to be centralized in an organization. Why? Our environmental health champions, they're becoming a lost generation. They want to retire. They've been protecting the flock for a long time. They've been moved around all over the place with COVID response. That information has not had time to be set down and solidified. And some of that information isn't something you can just read out of a book. I needed to do stakeholder listening sessions, you know. And so what's going to happen? It's the next generation that will learn, they'll lead. And so if we match child providers with public health students to do their practicum, again, it's the same cycle each time, but yet we can advance things as we go through that practicum cycle. Then we get health positive behaviors for generations to come. Seatbelts. The seatbelt campaign was, they used children to target the messaging audience. Daddy, I don't want you to die. Strap up. That's a pretty large example, but now we all use seatbelts and we enjoy seatbelts. We feel safer. There we go. So I got stake in the game, not because I'm passionate about it. I've got experience on my belt. I got a next generation egg too. On the left, my daughter, 4 months, 4 hot months of kindergarten. Everything gets shut down. Her mother was talking a lot about public health during that time, a lot about stark realities, bus drivers, exposures, things like that. And her father has a chronic illness. And so she just decides she's going to make a video. And she goes through these videos for children. We have a community stories page, next gen page, and she just flips these out on her own. I don't do anything. I just hold the camera. And she is growing up in a world that is going to have a lot of struggle and strife. So we're turning that into agency, not stress response, agency. So thank you all for being you, wherever you are in this, because together we will get through this and together we'll be okay. So we'll follow up the cleaning guidebook. You'll get it through some mechanism. Check out our website, socialsafetyinitiative.org. We are upgrading the website. We are volunteers. And I will say it out loud, we do not like GoDaddy at all. Like their staff, like their workers, do not like GoDaddy. And then we have a teachable site. All of this stuff is free. And we have a YouTube page. So that's pretty cool as well. And then we constantly have practicum opportunities. So with that, thank you for listening. I think I made it just in time.
Great, Lorelei, that was really interesting. Yeah, so I wanted to maybe just start with thinking about your focus on the janitorial staff and lung health outcomes. And maybe I'm interested in also thinking about the children in the childcare facilities and thinking about how much emphasis in your work was on. It sounds like some of that might already be coming from the Department of Health as they organize and decide which disinfectants can be used, but I'm curious how that played into your thinking here. So not only the lung health outcomes for the janitorial staff and the people who were using, or whoever it is that's using the disinfectants, but also the children that are in the buildings or the rooms.
So my focus was ECE centers. Now, my technical lead focuses on indoor air quality, all of the schools. Fantastic champion. So you have different institutions there. It's more highly regulated. If you have a child care center, morning and evening after school, those centers have access to trained janitorial staff. Wilmoa, there's a whole network right there. And it turns out COVID-19, you don't have to do anything different. So that cycle's going. Yep. And also there's a distribution network. The schools get together, they have the janitorial staff, they meet every quarter, the presentations they do to each other. The one person for indoor air quality, she presents all around on that. And so janitorial staff or staff that are trained to support janitorial staff. Now there's a lot of cracks. You know, you find out the 16-year-olds are helping out after school because we're all just doing more janitorial stuff. Can they get to bleach? You know, that's where it gets dicey. Are there enough janitorial staff? That's a big problem. Are PTAs, and I don't even want to call it PTAs, that's unfair, but parents, are parents pushing teachers to use disinfectants? Are they sending in the wipes so that they can use? Wipes are disastrous for the environment, but that structure is a well-worn structure. And so that is not as of much concern as it is communication. It's also primarily English. And so those conversations that are be having, King County local health jurisdiction does a great job of pulling that information and getting it out as it needs to get out. But it's spotty across local health jurisdictions, depending on the funding. The childcare centers, that's just a whole gap. Schools are doing well though. They've got a lot of support, and they had a lot of support from the beginning. There was a work group, great work group, and they would talk about what's coming up, what is going to happen for school camps, what's on the page for reopening, what's going to change with quarantine. There was all active support for that. Childcare centers, people could pop into them. That didn't exist.
Yeah.
Does that answer your question?
It does. I'm also curious about the children like exposed to the disinfectants. Are there concerns with that? Or, I mean, bleach is, yeah.
So quaternary ammonia products, the pink stuff, when you go into Walmart, probably, these things are grandfathered in. These things are under high scrutiny for reproductive disorders. So you've got pregnant people who are there in the child care centers. You have kids in early development for lungs. If it's an endocrine disruptor, now we have obesity outcomes. We've got a lot of problems. Okay, so if we're using quats, especially if it's not treated as a disinfectant, that indoor air quality is seeding long-term health outcomes that aren't good. Now, bleach isn't terrible. If you vent it out and you use it right, you're really safe. But bleach triggers asthma. So if you're an asthmatic, you really don't want your asthma triggered. If you're a child with asthma, that's a crisis. You know, especially if you're in a childcare center, your parents aren't there. These disinfectants cause asthma. So now you can develop it. Childhood, later in life, you have a predisposition to it. So there's absolutely, if you smell it, it's in your lungs, that's a problem. And so in our guidebook, we list what the EPA registered disinfectants are that are, I would say, less harmful, easier to use, and just generally going to decrease those health outcomes. So there is a huge concern, whether it be right now or whether it be long-term.
Yeah, that's super interesting. I years ago moved to just trying to use soap and water in my house and not using any cleaning products. So at least it sounds like there's some foundation for that choice.
That's what I do. I just wash everything, unless someone's sick or when I finally get around to washing the toilet. Or the towels, you know, if you're not steaming, you know, I can't say to recommend doing this, but I'll like dump some bleach in there, you know. Sanitizing cycle on your dishes, you got to get the grime off, but you know, we don't get sick a lot as a result because soap and water is beautiful. You just got to use it.
Right. Cool. Okay. So we have a question from the audience. How do variations in state by state and county by county public health policy implementation programs figure into the definition of health equity?
That is a fantastic question. That's a very complicated question. Not exactly an answer, and I will answer it, but I should tell you that the last time I looked at the CDC website, it said use soap and water and disinfect. Like it just says disinfect on there. So institutionally, we've already got a system where the messaging from that institution is in conflict with the messaging from like our Department of Health and what we're trying to do. It gets confusing. State by state, this is why the organization, the organizational overhead from the nonprofit that got us all together was helpful, because then we could all converse. Different states have different laws. Does it say bleacher alternative? Does it say disinfectant? Different states have different capacity within the Department of Health. There's a lot of capacity and training and knowledge of health equity and what that means. Health equity is adaptation. All equity is health equity. You know, what do those words mean versus equality? And so everyone's in a different stage of learning. Every institution is a different capacity. So if I think I'm getting to the question right, that would be a great dissertation. That would be a great dissertation, because the people that know and feel it and can talk about it aren't going to have the time to really dig into it. Now, at the Department of Health, they have an entire group that focuses on health equity. So whenever I was doing my stuff for trying to get executive order to get childcare sites for profits to the state janitorial contract, there was a whole team that reviewed it through an equity lens. They were skilled. And then it went to a team of lawyers that also had a health equity lens. So we're very fortunate here. I can't speak for other states, but I have a general feeling in what I've seen that it is dispersed, it's at different levels of learning. There's different populations it affects. You know, I identify as neurodiverse. How does health equity impact that one? What are the levels of intersectionality? So I'm really not answering your question. I'm giving you things to think about. And I would say that that is not an answer I could answer, but there's very well organizations like Health in All Policies is a thing we have at the state. You know, those are groups that are expanding the nation that are starting to do that work. So just start asking around and you'll find them.
Cool. Well, I have one that I would like to just use to build from that. In your opinion and or experience, what are the components we need to correct in order to achieve health equity? And then what are the challenges with that? So in your, like, if you could make all the changes that needed to happen, what needs to be corrected for us to get to health equity? And why can't we make those changes happen?
One, and we can, and that is to formalize a Master's of Public Health practicum. I've been doing it for about 7 years, and we've seen these outcomes already. But what does that do? People are in their communities. They are coming in with this knowledge. They're putting it in a structured way to produce things with the lens of their own community. So they can, it's like the weatherman, you know, the nation comes in and says there's a hurricane, but you look to the weatherman to say, okay, 3rd Street is going to be closed. It's going to be flooded. Get out of 3rd Street. But if you go up the mountain a little bit further, you'll be safer. Don't drive for a couple of days. It's the same thing. We need professionals that are coming in who can overlap. And when you say overlap, they're not working on the same thing, same competencies, but some might be interested in policy. So they can take the time to dig into that. What is the policy and where can it shift to be more equitable? And who is the point person, organization, people? What do they need to know? What documents can we produce? You know, or this one, okay, we've got a whole group that we have attention in through this nonprofit that does licensing. What do they need to know in order to slide a module in to watch CEU credits? Public health students can produce CEU credits. They just need a little structure to help them out. And then what does that do? That has a resource that everybody can use because it's all on a topic that affects all of us. And so if you want to close the gap with health equity, one, we need a pipeline for these students. They're going to get out there. And then who's going to actually get chosen to do the work? Now, you know, we've got a lot of social problems with that. What's the name on the resume? The whole way through, you know, you could go on for a long time. They need stuff on their resume. They need to be able to speak and understand what they're doing. They need an option to move, to practice moving the needle. And again, they pay for the practicum. They need a site that's outside of their institution. And with COVID, especially, with everything getting shut down, and with the fact that nonprofits, they're just, if you've ever run a nonprofit or been in a nonprofit, 1, you're underfunded, 2, you're overworked, and 3, all of a sudden you get a practicum student, but they're only for 3 months. It sounds great, have the help, but then you got to train them up. So if they're in a system where they're already doing that, then in 3 months, you get a 40-minute training from the gentleman in the Air Force. Then in 3 months, you get a cleaned up guide. Then you get the training videos. Then you get a person working on policy. And so it advances, and it advances from the communities themselves, from our incoming leaders. It doesn't come top down. And so it just embeds it. I'm really hoping that we can get attention to formalize our public health practicum, our public health practicum experience. I've done it at many organizations. We've always gotten students in there. It's very doable. There just needs to be a champion to see, and this is where the funding comes in. Like, who does the funding come from? It's all networked around. Is it the universities? Is it DOH? Is it a collaborative partnership or a volunteer nonprofit? Grants are really hard to write. They're really hard to write. So that's what I would say, is that one fix would move us very far.
So it sounds like just really having somebody who's part of a community who can look at the unique characteristics of that community and try to work towards correcting what's wrong in that community is a way. That's how I'm thinking about what you're saying. Does that sound?
Yeah, and if you think about no villain in the story, it's a gap analysis. They have a good, clear idea with their training on where the gaps are.
Right.
Yep, and so they have capacity to start filling those gaps. And so it's these problems are not, they're institutional change problems. And so there's no one villain or no one organization that should be correcting it. These are problems that have surfaced and arisen because we're now operating in systems. We're globalized. Everything's changed. I grew up analog. It's now digital. And so as we expand, more holes happen. And so we need to find a way. I wouldn't even say to plug the holes. I would say to grow that population, these populations, these organizations and communities that are falling down. We need to bring them back up.
Yeah. Okay, great. I actually could spend a lot more time digging into this, but I'm going to move to a different type of question. Do you have a way to get through to people or organizations that just don't trust public health practitioners? And as you answer that, I would be curious as to why you think public health practitioners aren't trusted.
I spent a year of my life in this nonprofit, and I've come to terms with it, but it was heartbreaking. Facebook page, I put up a little wear a mask song. Person in Africa was the one who wrote the song. Person in India was the one who made the graphics. The comments, instead of having just to delete each one, the comments, you can actually block words. Okay, so I get through the 30 typical words you can imagine that are just egregious. I get down to having to block the period, because it was just disastrous. It's a kid's song. So we need training in public health and awareness. First grade, everyone knows fire safety. Everyone knows who the fire marshal is. We need public health professionals to come in. There was a campaign a long time ago. I had stickers. This is public health. It was on trash cans. It was on all of these things, safe water, these kind of things. My father, he's 78, my father, over the course of this last year, is now recognizing what public health is and is getting ticked off at public health for not promoting what we do. Well, that takes time and people, and darn it, we've been so underfunded that some counties has half a nurse FTE. So what can we do? We could take ownership. A lot of times in academia and public health, there's so much to know that you don't want to speak on it. You got to get it right. You want to get it right. You don't want to say the wrong thing. We need common messaging. Common messaging is hard. We also need a common framework for discourse. I always go back to the stress response system. You can name the threat, name where it is predictable, and make it controllable. All of a sudden the person this appraisal system shoots off the stress response before it gets over here. And so there's that in the way we frame it. And sadly, I'll just give you an example. I had this one person in my life who just did not like wearing masks, just thought it was just government individualization. That is a strategy in evolution. Community is another strategy. She just did not want to wear this mask. She came down with COVID. She was in the hospital for a long time. Come back out. A lot of people would say, oh, okay, you're going to wear the mask. No, I'm not going to wear the mask. I don't want to be silenced. And so I actually found that I said, if the government would have just funded public health, this wouldn't be a problem. And you wouldn't have to wear that mask. We should just fund public health because the government didn't make that decision in their budgets. And now you have to wear the mask. She resonated with that. And so I guess this whole point is to say, I have tried a lot of different messaging techniques in a lot of different ways. And we need to be seen as community doctors. We need to call ourselves doctors of community. People need to see us training. They need to see their own community members training. That's where we become trusted. And it's only through action and training that you build individual trust. It's not through a booklet that you put out there. It's a helpful booklet, but it's not going to get us there. And we also need to not burn out, because that happens.
Yeah, we have, maybe this would be the last question, but just as you were answering that, I just thought currently, I think we can all acknowledge that the distrust of public health officials is quite high. And I'm wondering if it's always been like that and we're only just becoming aware of it, or if it's more about the current situation, that's something about the current situation that's made it worse.
Two responses as examples. We had one of the first examples of aerosolized virus transmission, not surfaces. Sent that over to the WHO, not we, me, public health sent that to the WHO. And they said, we're not gonna pay attention to that. It's not aerosolized. 8 months later, there's this big argument going on between the WHO, which the WHO has good things to say. I'm not tearing them down, but they're having an argument with our side of the world, especially Pacific, about, please, can you just call it shared breathing air? Can we just call it that, where the threat is? Then I find out last year, the WHO developed its first panel, its first scientific advisory panel. I'm like, why don't they have one before? Wait a minute, this is an institutional problem. Okay, so you've got this real time going from research into education into training. Everybody's all over the place. The CDC didn't change its mask recommendation until we were 5 weeks into getting our bus drivers masked, which was a feat. But I'll remind everybody that when we had the last administration come into office, we lost a lot of EPA staff. All of a sudden, the climate change page went down and the freedom fuel page went up.
Yeah.
There's a discourse there. And what we need to know is that we have values, we have beliefs, and we have personal norms. Personal norms are based on risk assessment. And the risk assessment is not clear. Where's the threat? How do I predict it? How do I control it? It's just not clear because we don't have the science education built up. And we've got some really chaotic stuff going when you get to politics that muddies the water. And we don't have funding to have institutional cohesion. Again, CDC still has disinfectants on their posters last time I looked. That's a problem when I come in and say don't use disinfectants, and they're like, but we have this poster up and it's the CDC and we trust them more than you.
Great. So with that, I think I want to just thank you for being here. This is really fascinating, and I'm thankful that you were able to make it. And so with that, I think we have our final slide and we'll say goodbye. Thank you.
Thank you.